I am an anesthesiologist, but I have an interesting job in that I also direct our shelter medicine program, and we run a spay-neuter clinic on campus for our students. So at our school, my 25% of my job is running clinics upstairs for patients of our veterinary teaching hospital with complicated diseases where they all get individualized protocols. And the rest of my job is running anesthesia downstairs, where it's a large volume of animals with basically one protocol, one for dogs and one for cats. And so this talk is really kind of a collision of those two worlds. And so it's not really that there's anything different about being upstairs versus downstairs, and that if you come downstairs, you deserve this level of care versus if you come upstairs, you deserve some other level of care. And I think that really kind of goes back to what Dr. Miller was talking about last night, in that what our patients deserve doesn't really change based on their ownership status. And so what's really different about those patients? Why is our management appropriate downstairs different than what's appropriate for our patients upstairs? And what it is the patient themselves. So when you have patients within the shelter environment that have different circumstances like advanced age or other diseases, they really deserve a customized protocol. And so if you take one thing from this lecture, it would be that you consider your patients as individuals and think about whether that standard protocol that you always use that works really well, that is great for 99% of your patients, is that the best choice for this particular animal that has special needs? I always get, whenever I lecture to shelter people, tons and tons of questions about protocols. And so we probably will not have time to answer those all today, especially because I know you guys will probably want to get to lunch. So I did bring cards, and I have them up here. So if you want to take my card, you can certainly email me with any specific protocol questions or anything about your shelter that you want answered. And then, if you give me a couple of weeks to get back to you, I promise to try to answer all of those. But that way we can get out of here on time. So what we're going to cover today is a little bit about why we have geriatric pets in the shelter and what may be happening with them. I'm going to talk about the physiology and pharmacology of aging, and that material is tough for me. So I have notes, and it's kind of, dry. Physiology was not always my favorite class in school. So we'll get through together. I may gloss over it depending on how timing is going, because I want to make sure I have time for the more, in my mind, important stuff, which is the clinical impact, what you actually do in the clinic. And we're going to have some do's and don'ts, some things that I think you should be doing or should not be doing for older patients. So just bear with me on the physiology part. So what we know is that the population of pets that we're seeing that are geriatric is increasing. It's now 30% of the pet population is geriatric, and 1/5 of all dogs in the US are over 10 years of age. And in the private practice side, more than $1.5 billion is spent annually on care for geriatric pets. So this is a growing sector. It's 30% of the pet population by some estimates. And we know that these patients have special needs. And the thing to remember is that just being older increases your risk of anesthetic death. So there's a big anesthetic risk study that comes out of the UK by David Broadbelt, who's an anesthesiologist and epidemiologist who does a lot of work. And in that paper, they showed that if you're over 12 years of age, your risk of death under anesthesia is increased by as much as 7 times. So it's a serious increase in risk factor that we need to take carefully. So how many of you have heard age is not a disease? Everybody's heard that. And in fact, somebody at AVMA gave a talk, Anesthesia for Geriatric Pets, Age is Not a Disease. And I was like, well, great. Who do I think I am? I'm giving like the opposite talk. Age is a disease. And so what do I mean by that? Why am I using that as my title? Well, it's kind of a catchy title, gets your attention, kind of going against kind of your ingrained belief. But what I really mean by it is that age is something that we need to take into consideration. We need to take it seriously. We need to pay attention to it because it has such a strong impact on the risk of death and the risk of how the patient is going to do. And just by being older, there's a lot of changes in organ function, and your pharmacology, your ability to metabolize drugs is decreased just by being older, even if you're healthy in all other respects. So the way I say it to my students is, would there be a specialty of geriatrics, which there is in humans, if it wasn't something that we need to take seriously? So that's what I mean by it's a disease. We need to pay attention to it. We need to customize our anesthetic protocol accordingly. So within shelters, we know that as shelter euthanasia is decreasing, we are able to help more and more animals. So animals that in the past wouldn't have had a chance now are getting adopted in many, many communities, and these animals have special needs. We also know that in order to make those animals as adoptable as possible, you don't always necessarily want to sign up to adopt a 12-year-old cat and then immediately take it to the veterinarian and get a dentistry. So many shelters routinely provide dental care as one example of a procedure that's always done on an older animal, makes them more adaptable, helps the owner kind of wrap their head around what's the burden of taking this older pet going to be. And the other thing is that as shelters expand our services into the community, and we know in spay-neuter we're reaching more and more different populations of folks that need our help, it's not just going to be that low-hanging fruit, that healthy puppy and kitten that's coming to our shelter for spay-neuter or coming to our community spay-neuter clinic for spay-neuter. It's going to be different categories of animals, and we need to be prepared to make sure our protocols are safe for those animals. Other minor medical procedures, a lot of animals with mammary masses we're seeing, a lot of other underlying conditions that our shelters are now able to manage those conditions and keep those animals until they're as healthy. I know some shelters where, even animals with, diabetes or DKA, those animals are managed and stabilized and then placed. So those are all comorbidities that affect anesthesia. And our standard shelter protocols, which are great and need more acceptance and support in the veterinary community, may not be acceptable for these animals that have other conditions. So is age relative? What do we mean by geriatric? So for the purposes of this talk and most of sort of the literature about anesthesia, geriatric means an animal or person who's lived 75% of its expected lifespan. And obviously the lifespan is going to depend on species, breed, and size. So certainly while I will insist that it's a disease, it's not about a number specifically. You have to look at it in the context of what's expected for that particular animal. And then we know that it's going to vary a lot with the individual. Like I have had clients with 20-year-old dogs, 22-year-old cats, I think is the oldest I ever knew. So if you're going to live 22, if you're 12, that's not 75% of your lifespan. So we want to make sure that we consider it in context of the individual animal. This was a cool paper in Current Biology, just talking about kind of our sort of common belief that larger dogs don't live as long as small dogs. And you can see that there's definitely some variability in the data. So there's some that are off the line. But in general, as you get bigger, if you're a dog, you don't live as long as if you're smaller. And certainly we know that giant breeds don't tend to live as long as smaller breeds. So I thought that was interesting. So basic things to consider. We sort of all know that our sort of thoughts about sensitivity to anesthesia and vulnerability to side effects of anesthesia are definitely going to be increased in the older patients. And any alterations from our basic physiologic parameters are going to affect our care of them. What we're going to do now is we're going to walk through the physiology of aging and the impact on the different body systems to talk about what changes as you get older. I don't know, it's definitely, I feel like cutting in and out. So you guys still good in the back? Kind of makes a creepy noise up here, so sorry about that. So basically, just by your age, your basic metabolic function is relatively uncompromised just by age. However, all of your organ reserves and organ function are going to be decreased. And most importantly, your ability to handle physiologic stress, and anesthesia is a huge physiologic stress. It's a terrible thing to do to an organism. Is decreased. You just can't cope with challenges to your physiology as you get older. But many geriatric patients also have specific diseases of specific organ systems that's also going to impact all of these things. And if you have an animal in a shelter who's in poor body condition or who's subject to stress or who is doing poorly for other reasons, that's going to exacerbate those other changes that you'd be seeing anyways due to disease. So the cardiovascular system is the most important system for anesthesia. I always tell my students, you have to listen to the heart, you have to know about the cardiovascular status. And the older patients are going to have decreased reserves, and they have a much higher incidence of cardiac disease. Up to 58% of dogs over 9 years of age have chronic valvular disease. So those little terrier mixes, those little Bichons, those little Yorkie mixes, which some of my shelters in Massachusetts actually getting quite a lot of these little dogs. Those dogs have chronic valvular disease until proven otherwise. You can just assume that they do. So clinically normal geriatric patients may have a reduced circulating blood volume, which is very, very important because we give them isoflurane under anesthesia, we vasodilate them, and all of a sudden they can't tolerate that isoflurane anymore if they have a decreased circulating blood volume to start with. So those are those patients that are going to be really tachycardic on you. They need more fluids than we would typically give in a shelter setting, which is usually none in my shop. They also have changes to the structure of the heart itself. So the heart gets thickened, you get more collagen in the wall of the heart, you can get calcification of the vasculature, and all of this decreases the patient's ability to compensate for blood pressure by responding with the vasomotor system. The reserve of the heart due to myocardial fibrosis and ventricular free wall thickening is also occurring. So sort of the take home is that you have a decreased efficiency, ability to work under stress of the heart. Decreased cardiac output. And also, unlike our pediatric patients, which can only respond by increasing their heart rate, geriatric patients are usually maxed out at the heart rate. So they can only respond by increasing their stroke volume. So volume is really important. But at the same time, we're always kind of worried about fluid overloading these older patients as well. So it's a delicate balancing act. This is all just a summary of the cardiovascular changes. So decreased compliance of the arterial, decreased myocardial compliance, decrease in the maximum possible heart rate, decrease in the maximum possible cardiac output. So they can only achieve so much when you challenge them. And then blunted responsiveness. So when you challenge them, when you create hypotension, when you ask them to respond, they're just not going to do as well as that younger healthy patient. So they're much less able to adapt to those physiologic stresses. Same thing in the lungs. So lungs also very important, especially if you're using gas anesthesia. Essentially, same thing. So you have decreased compliance, decreased ability to increase your lung volumes. Everything is less resilient. You have more fibrin in the lungs, and it's less able to expand, more airway closure. And all of that decreases the efficiency of gas exchange, and it's so harder for them to do well. So basically what this does is increase in shunting or VQ mismatch, which is one of those terms you learned in school that you don't think about much. But essentially, if they become hypoxic, they're not going to tolerate it as well as the young healthy patient. They just don't have the reserves. So you have less time to intervene if there's a problem. So much better to prevent a problem than to get into trouble with these guys. And just like we learned about this morning, a fair number of our little guys may be a little bit overweight, and that's going to exacerbate those problems they have in ventilating. If you have a rise in their carbon dioxide level or a decrease in their oxygen, their responses are physiologically blunted, so they're more likely to go apneic on you under anesthesia. So you're going to need to be prepared to provide ventilatory support for these guys. So for their brain and their nervous system, also an important system, as you age, you actually lose neurons. Explains a lot about sort of challenges I have in my life. But their size of their brain is actually going down as they get older. And so they're less able to cope with what you're asking them to do. You can have increased cerebral spinal fluid and decreased cerebral blood flow. And I tell my students, really your job as the anesthetist is to maintain blood flow to the brain, heart, and kidneys. That's what you need to do under anesthesia while facilitating surgery. So that you have challenges there. Depletions of central nervous system catecholamines and other neurotransmitters, which basically explains why they appear to be so much more sensitive to sedatives and the other drugs that we give to achieve sedation and anesthesia. There's also changes in the blood-brain barrier as you age, which will affect sensitivity to these drugs as well. And in general, the older patient is going to have a decreased MAC. So remember, MAC is the dose. You can think of MAC as the dose of inhalant that we have to use, the minimum alveolar concentration that's going to achieve anesthesia in our patient. That will be lower in your older patients. A decreased requirement for local anesthetics, so you want to think about dose reducing. And that pretty much goes for all drugs that we would give intravenously, and we'll talk about that more in a second. Kidney, the older patient has decreased glomerular filtration rate, much more difficulty handling water and salt loads, so you want to be judicious. Definitely they need fluids, but you want to be judicious. They have a decreased ability to concentrate their urine, decreased ability to conserve salt. If you have decreased blood flow to the kidney, that's going to impede renal perfusion, and especially for our cats. I basically consider all cats have kidney disease. We just don't know it yet on their lab work. So you really want to protect those kidneys. If you don't monitor blood pressure routinely, and most of us don't, because if my surgeon's going to take 5 minutes, that's not going to be that significant. But if it's an older animal and the procedure is longer, these are the animals that you really want to be monitoring blood pressure, because you want to protect those organs, especially the kidney. Very, very vulnerable to the consequences of kidney injury and changes in hydration status. For the liver, you will see an increased drug half-life and duration of effect. And this is due to a couple of factors. One is just a basic decrease in the liver mass of up to 50% in the aging patient. And that leads to a decrease in the availability of hepatic enzymes. And that's basically how you wake up from injectables, is your liver has to metabolize them. So less liver, less ability to metabolize, less goodness of waking up. So that's a problem. And the second is that as you age and your cardiac output decreases, that will decrease blood flow to the liver. So that's a second hit that sort of affects why older patients don't seem to metabolize and wake up from anesthetic drugs as easily as our younger guys. And this is especially true of the lipid-soluble drugs, which is a fun thing I discuss with my students, but most of the drugs are pretty lipid-soluble, so you can kind of ignore that. And then just body mass. So as you age, and Dr. Ehrman talked about this morning as well, you're going to have decreased muscle mass, and that affects the tissue, that basically affects the volume of distribution for drugs. So you'll have less lean tissue mass available, less places for drugs to go, you could think of it. Decreased plasma proteins and decreased total body water, and more fat, as we all know. So theoretically, this means that highly protein drugs are more available. This used to be a huge problem when we used things like thiopental, which my students today have never used thiopental. We don't know if we're going to get that back or not. So that's less important with today's drugs. But we do have an increased volume of distribution for most drugs, which is an actual problem. So the drugs are going to hit them harder. These are all just reasons why you see that. So their metabolic rate will also be decreased, and one of the things that this can affect really significantly is the ability to thermoregulate. So when we put them under anesthesia, we sort of take away all of their ability to thermoregulate, and then we give them drugs like opioids, which change the way the brain thinks about your temperature set point. So we just, in summary, need to do more to support the older patient to make sure that they're maintaining homeostasis. They're much less able to maintain their core body temperature than your younger healthy patient. And the other thing is that if they are shivering, that increases oxygen demand, which increases the workload on the heart, which we already talked about being detrimental to the patient in general. So you really want to do your best to keep them warm. I already talked about how they seem to be increasingly sensitive to many of the drugs that we use, how MAC is decreased, and how you can expect a longer recovery time. And so here, owner education or shelter staff education, or depending on your situation, is important. A lot of times you get complaints when that older patient goes home, they're not back to normal by that afternoon. Well, yeah, they're not gonna be. Like, you can expect them to be out of it for at least 24 hours after anesthesia. And in a shelter setting, that may be really important. How are you going to monitor that animal overnight? How are you going to make sure that he's okay after a big anesthetic event? If you have somebody, you know, with a fracture or a big surgery, you need to be prepared for that. So in the spay-neuter clinic that I work in, everybody gets a screening exam, but it's a quick screening exam. It's basically, is their cardiovascular system healthy? Is there any big flags? You know, are they actually already spayed and neutered? Those big, quick screening things, you know, it's 5 minutes per patient or less because we have the big volume of animals to get done. But with these patients, we want to be a little bit more thorough. We want to go through that thorough physical exam like we talked about last hour, because many of them are going to have existing comorbidities that have not yet been identified. History is a big challenge for us in a shelter environment. We may or may not know anything about their life before they came in, but if you have the luxury of an intake questionnaire and an owner to answer those questions, and you can see, oh gosh, you know, this pet has some dental challenges and he's going to be facing an anesthesia, it's worth asking the question, has he had any exercise intolerance? In people, inability to exercise or coughing with exertion are predictors of poor outcome after anesthesia. So if you have the chance to get that information, that could be helpful. Any medications they've been on, any conditions that they already know that they have. And then same thing with our pre-anesthetic testing. I'm not a big one for arbitrary pre-anesthetic testing. That's been shown in humans that it's not a good use of resources. So your healthy patient that's under 5 to 7 years, depending on your protocol, that's presenting for spay-neuter does not need blood work. Does not need blood work. But your older patient that you're suspicious of other diseases should have that regular minimum database, really should have a CBC chemistry urinalysis at a minimum before undergoing anesthesia to make sure what their basal, their bottom line organ function is as best we can. And then potentially thoracic radiographs, imaging, and maybe even an EKG depending on what you're finding on your physical exam. And that's going to obviously increase the cost and sort of change the picture. And it's not always possible. This is the ideal. When you're moving these patients around, a lot of older patients have pre-existing pain, pre-existing arthritis and other painful conditions. So you really want to educate yourselves and educate your colleagues about handling them gently. We don't want to exacerbate neck pain or back pain or joint pain that they have already with our positioning for surgery. Some of us do fairly aggressive positioning, you know, just to get everything just so straight. These are not the patients that we need to be doing that. So being very careful when we tie them down, very careful when we stretch their legs, and when we lift them, when we pick them up. You don't want to put pressure directly on the abdominal organs. If there's any kind of pathology in the abdomen, you know, we've seen tumors get ruptured just from people picking them up aggressively, and now you've got a hemoabdomen on your hands. That's not what you want. So very gentle handling. They tend to have a lot of anxiety. A lot of our older patients in practice are on things like melatonin, like just to help them cope with life as an older being. So you want to think about that. How mobile are they? I have a dog, an 11-year-old collie mix, won't walk across slippery floors. So things like that, you need to kind of modify the clinic environment to make these guys do better. And then while they have anxiety and they need sedation, they're going to be much more sensitive to those drugs than your typical patient. So you need to cut the doses back. So I want to talk a little bit about how to design a protocol, kind of going back to school, because most of us don't do this on a daily basis because we're using usually it's a chart that, you know, we just pick and we go. So when you're doing this, you really want to think about the particular temperament of the animal that you're working with, the breed and species that you have, any underlying medical conditions that you've identified on your minimum database, and then anything else about the procedure. In people, they know that doing the procedure under sedation with a local anesthetic is going to decrease morbidity in those patients. So is it something that could be done under a local? You know, is it a little mass that it's a very calm patient, you can do local anesthetic and a light sedative? That patient's going to do better with that than with general anesthesia if they're older. And this involves considering their pre-medications, their agents for induction, and then just the whole plan. So this is a chart, my students will recognize this from school, that we use when we're talking about what we need to consider. So every patient isn't going to necessarily get all of these things, but we want to consider them for all the patients. So every patient is going to get a sedative, and we're going to consider what specifically about our patient is going to help us choose one of these categories or the other. Every patient should have, if it's having a painful procedure, it should have something for pain. We have lots of good guidelines from AHA and other places that say we need to provide pain medication, so that needs to be considered. Anticholinergics, if your protocol routinely includes anticholinergics, which many do not these days, but if yours does, these would be the patients where I would consider leaving that out. They probably don't need it. They already have a pretty high heart rate most of the time. And chemical restraint, you know, most of the older animals are going to be more tolerant for restraint, and they're not going to need such a profound pre-med, hopefully. And then, you know, is there anything else that needs to be put in? You know, are they having a GI issues, or is it a mast cell tumor, and we need to make sure they have famotidine and diphenhydramine on board. So the protocol is going to be determined more by the underlying disease than anything else with these guys. Most of the drugs that you guys are using, with one exception, is probably fine, and I'm going to tell you specifically my opinion about what those are. In general, you want to think about using things that are shorter acting and reversible. You may notice that they're much more sensitive to inhalants, so if it's a clinic like mine where techs are sent in the vaporizers and then they're running around, you know, just have them pay attention to that it may need to be a little bit lower for these guys. And I already talked about regional techniques, which may or may not be a problem. It's not that practical in a lot of settings, but just something to think about. A lot of people are afraid of acepromazine. It definitely can cause hypotension. You definitely should dose reduce, and remember that effects can last a long time. So warn owners about that, but I wouldn't be afraid to use it by any means. It can be a very useful drug in older patients, especially if they tend to be a little bit anxious. Benzodiazepines, normally we say they don't belong really in the spay-neuter clinic. They aren't great sedatives for young and healthy patients, but they are great for those patients with cardiovascular disease. Very minimal detrimental effects on cardiovascular function, and they are reversible. And in the older patient who's calm and doesn't have a lot of anxiety, they can provide excellent sedation. Also a longer duration drug. So here's my opinion. I personally do not recommend using alpha-2 agonists like dexmedetomidine in the older patient. And the reason for this has mostly to do with the profound cardiovascular effects. So we talked a lot about needing to maintain perfusion and all those organs that are already vulnerable. So you're going to get some vasoconstriction, which is going to decrease perfusion. But the big one is that decrease in cardiac output. So I tell my students, consider in your head, would you think that this patient can handle a 50% drop in cardiac output? Remember I said that the basal cardiac output in the geriatric patient is already decreased. So if your answer is, gosh, that's kind of scary, then you're going to say no to this drug. So I feel pretty strongly about this, and I think that, you know, we often get away with it, and maybe it may be okay for short-term sedation, but certainly for preceding a general anesthesia, I would avoid it. There are better options. Opioids are a great choice for the older patient. They're generally well tolerated. You may see much more profound effects than you expect, especially with older compromised animals. So you want to watch. Usually we don't worry about respiratory depression much in a clinical scenario. We always talk about it, we always think about it, but we hardly ever see it. These are the patients where you could potentially see it, so you want to be prepared for that. And you want to dose reduce, and then keep in mind that these are reversible as well. Although if you reverse them, you will take away their analgesia, so it's better to start with a lower dose, and you can always give more if they're not comfortable. NSAIDs, another one, really, really cautious. We talked about how their kidneys are vulnerable. If you have hypotension, or you're not measuring blood pressure, or you have decreased renal perfusion under anesthesia, that is going to increase the vulnerability to toxicity of NSAIDs. Times we see problems with NSAIDs is if they have pre-existing renal disease that wasn't noticed, or if they are dehydrated. So sometimes this becomes a quality of life discussion. So if it's an older animal with chronic pain and an NSAID is going to be the best choice for their pain, you may use it at lower doses if you're educating that owner and you're making that decision to prioritize quality of life. But in a peri-anesthetic setting where giving a dose could compromise renal function, I'm probably going to tend to avoid it unless I'm very confident that the dog or cat has good renal function and is well hydrated. So use with caution, if at all, in the older patient. Propofol. propofol is a drug that's kind of a mainstay for these older patients. Because it has extra hepatic sites of metabolism, it's an excellent choice for the older patient. However, remember that we can see profound cardiorespiratory depression with propofol. And we have studies in the literature that show for older patients you need a lower dose to achieve induction, and that they clear it more slowly. You know, we don't really think about propofol as affecting our recovery. The animals usually wake up really quickly, which is why a lot of people choose it in that sort of outpatient setting in regular practice. But in older patients, they don't recover as quickly. So you want to try to use the least amount possible. I tell my students just enough to get them intubated, and then you should avoid trouble with it. Is anybody using alfaxalone in their clinic? Has anybody heard of alfaxalone? Got 3 hands. So 4 hands. Alfaxalone is something that we have now in the ivory tower. It's a neurogenic steroid, so it's kind of the newest anesthetic in veterinary anesthesia. It's been available in Australia and Europe for a long time. There's actually some papers in the spay-neuter literature about the use of alfaxalone. There's a couple pediatric protocols with alfaxalone that are published. It has a very similar safety profile as propofol. And the thing that's interesting about it is that you'll notice that it's clear, and so it can be given IM. So I'm wondering if down the road, as we get more comfortable with it, if we're going to start seeing this trickle into some of our shelter settings. Right now, I think comfort and cost are big barriers that we're not probably using this much in shelter setting. We've had it at Tufts for about a year. I'm assuming they have it here at Cornell as well. So you may see some stuff coming out about this. We've been playing around. It's actually not a bad sedation. So there's one paper where they used it to sedate cats, and they had horrific recoveries, but they didn't really combine it with other sedative drugs. We've had some pretty good luck combining it with asapromazine and an opioid, and you can give it IM to that fractious cat that's sick enough and old enough that you don't think your normal cat protocol is going to be safe. And some of them seem to be getting sedate on it, and like they achieve like lateral recumbency, like you can ultrasound them and put a catheter in and do whatever you need to do. So we'll see if that gets picked up in the shelter setting more. Can you guys still hear me in the back? Kind of. I'll just talk louder. I don't really know. 3 mics, you'd think that one of them would work, but anywho. So for monitoring the geriatric patient, it's going to be the same as always, but these patients are more likely to be having complicated surgical procedures, meaning longer anesthesia time, meaning your monitoring is going to be more important. But you're not really doing anything different. You're still going to monitor the cardiovascular system, respiratory system, and temperature, just like you would on every patient. Ideally, you would have a pulse ox. How many of you are using end-tidal CO2 in your clinics? These guys up here, so and then you in the back are the outliers. So if you have something like that in your clinic, this would be the patient I would grab it and put it on if you're comfortable using it. Same for blood pressure. If you're doing dentistries on these guys and it's taking more than 20 or 30 minutes, you should be monitoring blood pressure. Dopplers are very inexpensive. You can get a Doppler for $600 through Parks Medical, which is in Aloha, Oregon. And the sphygmomanometers you can get at Patterson's or whatever your veterinary supply company is. They'll run you between $150 and $200. So expensive, but not as expensive as some of the bigger multi-parametric monitors that can run upwards of $4,000. So really, if it's more than 30 minutes, you should be doing blood pressure. This is critical for these guys. This is how you're going to protect their renal blood flow and their cerebral blood flow and make sure that, that you're keeping them safe. You could expect more hypotension with these guys than with your healthy patients. They are not as able to handle that vasodilation of the isoflurane as the younger guys. So in our clinic, you know, an older cat having a dentistry, that's the one that I am really loath to pull out dopamine or pressors. You almost have to like hit me over the head with a brick to get me to do it because I don't like doing that, and I don't like the decrease in perfusion that will happen. But those older cats having dentals, those are the ones that I start to get worried. So the more you can use those other drugs, those opioids, to decrease the amount of inhalant you have to use, the better those guys are going to do. And then you want to make sure they don't get really, really cold. One of the reasons I'm an anesthesiologist is because it was too stressful for me to try to worry about these patients for weeks and weeks, and then they don't read the book, they don't do what the book says they should do, and then the owner's mad at me. So I have a very short-term mentality. I just get it through the 2 hours, and then I give it back. But we need to remember that most complications occur in the post-op period. So especially in a shelter setting where you don't have the luxury of a 24/7 ICU to watch that pet, you need to make sure you have a plan. So if it's an older animal, maybe he goes first. Maybe you do it on a day when you have longer hours into the evening, or you have a plan for somebody checking on that animal if they're going to be unattended overnight, or you have them in foster around the time of the procedure to make sure that somebody's watching them, because afterwards is actually one of the most dangerous times. All right, so here's my do's and don'ts. So do pre-oxygenate. We'll talk about that in a minute. Remember that they have decreased cardiovascular reserves, so the more you can do to sort of give them that little boost so that they don't have any hypoxia, especially during transition periods, is really good for them. Definitely pre-medicate them. One of my biggest pet peeves is somebody says, oh, they're too sick or they're too old for pre-medication. You want to be careful. You want to dose reduce, but you want to do it. Consider a drug like propofol as opposed to ketamine. Ketamine has to be metabolized. I love ketamine, I use it all the time, but on my older guys, I'm gonna think more about propofol because they don't need their liver. You can give propofol to somebody that has no liver, complete cirrhosis of the liver, and they're still gonna wake up. So that's a positive. Think about reducing your drug doses, and sometimes this can be a lot, as much as 50% reduction in drug dose for some of these guys. These are the guys in my clinic that we're going to give IV fluids. We're not giving a lot of IV fluids in spay-neuter because the procedures are so short. But for these guys, we are. 5 to 10 mils per kg per hour is the rate that's recommended these days. We're going to monitor blood pressure. We're going to consider giving asapromazine if they're anxious. And we're going to avoid anticholinergics. I guess that's a don't. Here's a picture for pre-oxygenation. So what this does is it helps us avoid perioperative hypoxemia. So if it's going to take you a few minutes, if it's a dog having a long procedure, you're probably going to intubate it, especially if it's a bulldog. So if it's going to take you some time to make sure you get that tube placed properly, you want to make sure that you don't compromise that patient during that interval. So apply an oxygen mask for 5 minutes, and then that gives you 5 minutes to get the patient intubated and on 100% oxygen before he's going to desaturate. Avoid hypothermia. We don't want them shivering. We don't want to increase the myocardial oxygen demand. It also decreases coagulation. So that's a problem if you're having surgery. We ideally like the blood to clot. And it's also been shown to impair wound healing. And we already know these guys are going to have an increased healing time. So we want to make sure that we do as much as possible to kind of get them set up on the right foot so that they can bounce back quickly. Don't handle patients roughly. In my opinion, don't handle them with alpha-2 agonists. Don't be afraid of ACE, and don't use NSAIDs unless you're really confident about the organ function being good and you've had that conversation with whoever is the representative of that patient, whether it be the shelter or the owner. Much more at risk for complications than the younger patient. Biggest thing you're going to see is hypotension. So I wrote it 3 times, hypotension, hypotension, hypotension. You won't know it if you're not measuring it, and it's best avoided by using a balanced anesthetic protocol. So anesthesiologists always like to use more drugs. We don't like to use just one, we'd like to use like 7. And the reason for this is that if you use a lower dose of many things, you'll get the good effects of each drug and less of the negative effects of all of them. And they act synergistically together. And all of those things help us use less gas, and the gas is really the thing that's bad for the patients. There's a thing that I just want to raise to your attention because I think it's kind of interesting. It's called post-anesthetic cognitive dysfunction. And, I'll talk about that in a minute. So we talked about hypotension. Sorry, I got my slides out of order. So generally, if you're having a problem with hypotension, you want to decrease the depth. Your patients are probably too deep. Now, sometimes if you're a cat, for example, you have 2 speeds, awake and hypotensive. So that can be really challenging. How am I going to turn them down? He's going to wake up, he's going to bite the dentist, the surgeon's going to yell at me. But you want to run them as light as you possibly can. In the ivory tower, we use a fentanyl CRI to decrease that inhalant. Not all of us can do that in our shelter settings, but we could definitely add an opioid in some of our clinics. So consider adding an opioid if you can possibly do it as a CRI. That will help you decrease your ISO or your SIVO, which is what's causing the hypotension. Try fluids and then have some dopamine, although I will do everything possible to avoid using it. So this is the thing, the post-anesthetic cognitive dysfunction. So this is a thing in people. And so this editorial in the Anesthesia Journal for Humans was saying, should we just avoid general anesthesia in the elderly? And the reason they're saying this is because of this post-anesthetic cognitive dysfunction. And certainly it's not always possible because people need their heart valves replaced and they need their hips replaced and their knees replaced and whatnot. But we know that you take a hit. Your brain takes a big hit if you go under general anesthesia. So typically, it's not that they don't wake up. They wake up, they have normal consciousness, but what they've documented is impairment of memory, impairment in their ability to concentrate, changes in their language, comprehension, and social integration. Now, this will eventually resolve in most patients, but it can take months and months and months, like 6 to 9 months or longer after a general anesthesia before the person is kind of functioning near the level they were before. And some of us are starting to wonder, like, do we see this in these older veterinary patients? We certainly know there's a lot about cognitive dysfunction in canines in general, and does anesthesia potentially make this worse? So at this point in veterinary medicine, it's completely anecdotal, but it's just something to keep in mind and to pay attention to, and it's potentially another risk that we have to weigh. It's always a risk-benefit when we choose to do anesthesia on the older patient. So hopefully I gave you a little window into my world, and some of it will apply to your world. And I thank you guys very much.